you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
It's showtime.
Hello everybody, welcome to the Emergency Ultrasound Podcast. I think this is episode 3 or somewhere around in there. I've lost count by now. Today we're going to talk about DVT scanning. This is something that really excites me in emergency ultrasound. It's something that we can do really quickly. There's some pretty awesome research out in the last 6 months or so saying that we can do this pretty well. So we're going to talk today, we're going to really focus on two main questions. One is, can we as emergency physicians actually do this at the bedside? And more importantly, can we do it effectively? I mean, we've been doing this for a while now, so obviously we can do it. But how effective are we? Can we really send that patient home at midnight without the formal test and feel good about them actually not having a DVT? And then the second question we're going to answer is, how do you do it? That's more important. A lot smarter people than us can probably talk about all the research and go into depth about all the methodological flaws and how sensitive and specific we really are. But we really want to focus on how do you do it and give you some practical advice and show you how to do this in your emergency department on your next shift. So Mike, can you agree with me that DVT is important so we don't have to go into all this epidemiological crap?
No.
So I'm going to have to talk about all this?
Yeah, no, I'm not that confident DVT is important.
Okay, well, I am, and I hope everybody else is out there, so we're going to skip that. All right, so let's start with a case. This is you right here. You're flying home from San Francisco ASAP. You had an awesome time, and you were lucky enough to get seated by this gentleman. You talked to him for about 4 hours about ultrasound and the ultrasound section meeting, how cool it was, and then you fall asleep on his shoulder, which is surprisingly one of the most comfortable travel pillows you've ever slept on. But then you arrive home. The next day, you go to work your shift, and you see this gentleman again. He actually comes in, and after his transcontinental flight, he's had lower leg swelling and pain behind his knee since that time. So there's no tech on at night. This is his leg. And so obviously you're thinking DVT, but then he also tells you he's got a history of cellulitis, which complicates things a little bit. So what do you do? What do you do with this guy, Mike?
I'd probably take the Matt Dawson approach, just CT him, give him 2 liters of fluid, and check on him in an hour.
Okay, CT, MRI, 2 liters of fluid, and then see how he's doing, whether or not you're going to send him home. Now, I don't think that's probably the normal approach. I think some people may do several things. Maybe some people would give him Lovenox and antibiotics and have them come back in the morning for a formal scan. Other options are admit as cellulitis versus DVT. And of course, you're going to examine this guy and try to decide between these two. But I mean, we've got studies showing that our physical exam is not great for differentiating these two things. You may want to think about the escalating cost of healthcare and all the debate going on right now about healthcare reform before you automatically admit all these patients. But that's obviously a viable option. You also maybe just want to keep them in the department overnight, but you may have heard of a little problem called ED overcrowding. So that's not ideal. What if you could actually, in 5 minutes or less, answer the question yourself?
That's impossible.
What would you say to that if I told you could do that, Mike?
There's no way that's possible.
Well, Mike, let's talk a little bit about it, and maybe I can convince you that it is possible. So our first question is, can we do it at the bedside effectively? This is something that I've been doing for a while now, doing these ultrasound scans. But over the last couple of years, it seems like invariably I would do it, and I don't see a clot. But I just wasn't quite confident and end up getting a formal scan or having them come back for a scan the next day and then maybe even buckle and give them the Lovenox before they left to be super safe. But what really kind of gave me the confidence to stop doing that and just actually say, all right, you don't have a DVT, was this study. This study in December that's got a lot of, or came out in December in Annals, it's got quite a bit of press. And what Chris Blavato and Zhang did here is they took, I think it was 47 different providers, a really heterogeneous group. There were some residents there. I mean, it was actually all residents except a few attendings. And there were emergency medicine residents, family practice residents, internal medicine residents. And 44 of these 47 had actually never performed a DVT scan. They gave them 10 minutes of bedside training and set them loose. They enrolled 199 patients, found 40-something DVTs, and this is their sensitivity, 100%. So
That's amazing.
Yeah, it was pretty amazing. And obviously, some people would say this maybe doesn't actually pass the sniff test. I mean, obviously no test in medicine is 100%. And I think that was, I mean, if they had enrolled double that amount of patients, they probably would have missed one. I mean, they only had 200 patients. So I think they just probably didn't have enough patients in the study to actually miss some, because it's not going to be 100% sensitive. But this is pretty similar to other results. We've got a lot of studies showing that emergency physicians have greater than 90% sensitivity for ruling out DVT. But this is a study that really, for me, kind of pushed me over the edge and said, you know what, I can do this. If these family practice residents, after 10 minutes of training, could do it this well, then I need to just step up to the plate, grow a pair, and send people home without Lovenox. Also, can we do it quickly and effectively? Well, Dr. Michael Blavis published a study way back in 2000 showing that it takes about 3.5 minutes. So that's a pretty amazing result. And in his study, they had a very similar thing, 98% agreement with a formal study. They sent all of those patients for a formal study.
So you can take 10 minutes to learn how to do the procedure, 3.5 minutes to do the procedure, and discharge the patient 15 minutes after coming in? Is that about what's going on?
That's what it looks like.
Okay. Just making sure I had the time frame right on that.
Pretty incredible. And now, we should say there has been some kind of back and forth among emergency physicians about whether or not this 10-minute training really is too good to be true. And there was actually an editorial titled that by a Michael Blavis. I think that's how you pronounce his name. Is he an emergency medicine physician?
I think
he
so.
Does some ultrasounds?
Yeah, I think he did some ultrasound stuff at some point.
Okay. No, I'm obviously kidding. I'm pretty sure he would rip my throat out if I actually put him down in any way. So we definitely know who Michael Blavis is. He's been a great pioneer in emergency ultrasound. So here's another study looking at the amount of time that this saves that Dr. Blavis and Dr. Theodoro and a couple other people did a while back, and they showed that you actually save over 2 hours when you're talking about a bedside ultrasound instead of a consultative ultrasound. So a pretty incredible advantage to doing this at the bedside if we can do it accurately, which it looks like we can from that study we already talked about. Now let's talk about a little bit how to do this. I mean, they did a 10-minute bedside training, so hopefully in about 10 minutes we can show you how to do it. First off, we've got to talk about some anatomy, though. They're talking about a 2-point compression ultrasound exam in this study that Jang and et al. Did. And what are those two places? Well, first is the takeoff of the saphenous from the femoral vein, and second, the popliteal vein. Where are those exactly? Well, right here is the first one, the takeoff of the saphenous from the femoral vein, and then the popliteal is behind the knee there. So just to outline all of that anatomy a little better, you can see the common femoral from the iliacs, takeoff of the saphenous. Here's your point number 1. And point number 2, behind the knee in the popliteal. You got that, Mike? Is that all making sense?
I think so. Is that an ultrasound image we're looking at?
That's not actually an ultrasound. I'll show you some ultrasound images. Don't worry.
Okay, thanks.
I know you're getting antsy.
Yeah, it's been a
Just
while.
to be clear, this is very different than a consultative exam that you send your patient over for that takes forever. That's duplex ultrasonography. They scan all the way through the deep and superficial systems, and actually the deep calf muscles, the distal part there, those branches. This requires a lot of training, and it takes a lot of time, about 45 minutes to do this. There's been a lot of studies came out recently in the last several years showing that radiologists actually just doing these 2-point compression tests was pretty much just as accurate and just as good, especially when you talk about outcomes, as this comprehensive exam. So now we've translated that to emergency medicine and our bedside exam, saying, can we do this just limited compression? And so far we're getting some great results. But this is what it is. It's a focused exam. You look for clot in those 2 places, the common femoral and the popliteal vein. This is easily mastered in maybe 10 minutes, or at least in not a lot of time from the studies that we've seen. And it takes about 5 minutes. I mean, we just saw the study showing that it takes about 3.5 minutes when they actually looked at this question. So this is what that 2-point compression, that's what these guys did. They did that 2-point compression, and this is the sensitivity that they had. One thing to mention here, too, though, is that their formal or their consultative radiology exam at their hospital there, they do not look at the calf veins. So there could have been some missed calf vein thrombosis.
All right, so the question is, don't you need to actually anticoagulate those calf venous thrombosis?
Well, you're right. That is the question. I don't think there's an answer to that. I mean, 5% of clots are isolated calf, so presumably that's about how many you would miss in the calf if you're just doing this proximal scans, and what are the numbers for those calf veins actually going to PE? What's the percentage of that?
So what I've heard is that approximately 20% of your calf veins propagate to a proximal area. So they propagate to something beyond the popliteal, so above the popliteal. And then 50% of all DVTs progress to PE, or at least all lower extremity VTEs.
Okay, and those numbers are actually higher than the numbers that I've seen that say that calf DVTs actually only will propagate a much smaller percentage and actually go to PEs about 1% of the time. So you kind of have to know that risk, because the other risk that you're weighing that against is the risk of major bleeds from the anticoagulation, which we think is about 1% a year. So I think the jury
1.4 maybe, but still, like, I'm saying 10% of those calf DVTs are going to progress to above the popliteal, and you're only saying, or to at least PE, and you're only saying 1% is going to progress to PE. That's a pretty big difference.
Yeah, so I think the studies are showing a pretty big difference there. I think in general most people don't treat those calf clots right now, and I think that's what most people prefer. I mean, I think it's going to be on a case-to-case basis. If I've got a clot in my calf, I would prefer not to coagulate and just do serial exams. I mean, we would anticoagulate once it became proximal, and just with serial exams we could find that. Of course, to do the serial exams, you'd have to know it was in your calf, so then that leads to the question, would be looking. I don't think I really want to go into this question anymore.
That's fine. I think that, from my experience, most people tend to treat this as, you don't have a DVT right now, go home, come back later, get a formal study, or get a repeat study to make sure you haven't propagated. That's my interpretation of most people's practice at this point.
Great. And since I'm starting to confuse myself, maybe we'll just move on and talk about actually how to do the scan.
Don't worry, I'll write you a memo in a minute. You can understand what's going on.
All right, thanks. I'll go back and listen to this and make some sense of it. So hopefully you're very confused now about whether or not to scan in the distal leg. But I think most people, we're saying that scanning the proximal is okay. I think you ask pretty much anybody, and that's for most part the answer. So how do you do that? Let's teach you how to do that, and then you can think for yourself and look at the literature and decide how important you think the calves are. To me, I don't think it's important enough to scan. So let's talk about these 2 points. So how do you do it? That's the second question. It's really not rocket surgery. That's pretty clear by this 10-minute training study. Even if it's not 10 minutes and it takes 15 minutes, or however, if it takes an hour or however long it takes to get good at this, it's really not hard. It's pretty simple. Our first point in the anatomy that we talked about is the takeoff of the saphenous from the common femoral vein. Mike, can you hike up your leg? We'll do a quick video to show them where this point is.
Yeah, this is actually my leg in Matt's hand.
Actually, that's not true at all. But as you can see, this is uncomfortably high. You've got to go pretty high up on the femoral vein to find where the saphenous comes out.
You got to get up in their junk.
Yeah, you got to be brave. You got to go on up in there. This is what it looks like. You've got your artery there. You've got the femoral vein, and then you've got the saphenous coming off. This is the spot you want to be.
So Matt, do I want to be above, below this, or right at this level?
Be right at this level. You can compress a little above it, a little below it, and a little right at it, but I think this is kind of...
So the important thing is seeing that saphenous take off.
Yes.
Okay.
These studies are talking about these 2-point compressions, and so theoretically you're just compressing right here as your point number 1.
So if I just put my probe down on the thigh and I see artery and I see vein, that's not enough. I got to find the saphenous. That's what you're telling me.
Correct. Exactly.
Okay.
And again, just to remind you, and this is not an ultrasound picture, Mike. This is a drawing and actually an illustration. This is the point where you're looking at here, just to reorient you. And now here's a nice video for you. You see this? Oh, nice compression there. See that femoral vein completely compressed? But you're not high enough, right? You see no saphenous coming off there, so scanning a little higher. And there's the saphenous. So let's compress. And no clot. Beautiful. You're done. You're halfway done with the exam. That's your first compression point. That is a great looking...
What did the patient think when you pulled out the iPhone and started recording this?
So that's actually my femoral vein. And it's a really nice looking femoral vein, if I do say so myself. So the second point, popliteal. And this is actually my leg. Your landmark for this, you're going behind the knee, which is not a hard landmark to find. And I guess it depends on where you practice. Back where you're from, Mike, South Carolina, maybe it's hard to find the knee.
People don't have knees.
Sometimes. But if you can find the knee, if they're small enough that you can actually see the knee, you go right behind it. and that's where you're going to find the popliteal vein running down through here just behind the vein, or just behind the knee, I'm sorry. And here's a video of that. You got the popliteal artery, and the vein is more superficial, compressing, that's beautiful. There is no clot there, it completely compresses, those walls touch each other. That is not a DVT. So here are some other examples of DVTs. This is, you can see no compression and compression, it's not changed much, that's a DVT. Color flow can sometimes help you. You can see the artery pulsating here, the femoral vein with nothing coming through it. That is a DVT. But you really don't have to use color. I mean, these studies are just B-mode 2-point compression that we've talked about. So let's practice a little bit. Mike, what do you think? All right, we're compressing. Oh, actually, it looks like this is compressing, right? But it's pulsating. What's going on here?
I'm guessing you're compressing so much that you're compressing the artery, and that vein is not compressing because there's a big clot in it. There looks like there's some sort of like, I don't know, schmutz in the center of that vein.
Yeah, exactly. So if you're compressing so much that your artery starts to compress, you don't have to keep pushing to try to compress that vein. That's enough. There's a clot in there.
So the vein should compress before the artery.
Correct.
Okay.
That is a true statement. Now, what about this one? We just saw this, and it looks like they still have a clot. I just told you they did, so we'll move on to the next one. What about this? You got a pulsatile artery, good flow. You see anything in the vein? I see no flow. This is not a compression study, but this is just another example of color flow and how you will not get any through the vein if it's completely occluded.
Now, is it possible to have no color flow in a vein even though there's not a clot in it?
I feel like you're setting me up for something. Why don't you just...
So it is possible that if the flow is so slow in your vein, that you might not see any pulse, any flow in it. So that's why you can either use
augmentation, huh?
That's why you can use powered Doppler, right? Remember, a powered Doppler that just shows like the magnitude of flow rather than velocity, so it's a little bit more sensitive. Or you can augment something, so you can squeeze the calf and cause flow to rush up through the vein quickly.
Or you can totally forget about the color and just do the compression like these studies show. So it depends on how much fun you want to have with the ultrasound machine and how many patients you have at that time. But yeah, those are actually two great tips to use if there's some confusion. Here's another video. What do you think about this? See a pulsating artery?
I can't tell. The quality of this video is way too bad.
So
it looks like there's something inside the vein there. So like right next to it, yeah, there's that. Again, there's more schmutz. The schmutz sign. We need more schmutz signs in medicine. What do you think?
Yeah, as many as you can come up with. Yeah, so you're right. DVT right there. That vein is full of clot. What about this one? Compressing? Oh, did those walls touch?
That looks pretty good.
They did. That is, again, my beautiful popliteal vein.
It's good to know you don't have a clot in there.
It made me feel great. What about this one? Compressing?
No.
This is another popliteal vein. Looks very similar. Artery, vein, but that is not compressing at all. Would you agree?
Agreed. Not compressing.
DVT. Anticoagulate.
Oh, normal.
Normal. Oh, wait a second. Don't get crazy. You want to go up to that saphenous takeoff.
Oh, yeah, nice. Nice technique.
Now
and then
there.
you compress here?
Yes.
Look at that. Do you see that segue?
This is great. So no DVT. So you have just... They said it takes 3.5 minutes. You just rolled in like 6 patients in less than 2 minutes. I think that's a load of crap. 3.5 minutes per patient. We're way quicker than that. So I think any talk about DVTs, you have to kind of mention the Wells criteria, right?
Really? We have to get into this?
No, you're right. We don't have to. Let's actually just skip that and talk about the clinical algorithm. I think some people would say you have to talk about the Wells criteria because you have to do a pretest probability for these patients, but I say whatever. No, we're not going to get into that because you know how to use that. You know how to re-stratify these patients into low or moderate to high. And I actually went through all the literature and looked at these percentages, pre-test and post-test probability after D-dimers for the different categories of risk and kind of made my own algorithm. And then after that, I realized, wait a second, we already have this on the ACEP website that people much smarter than myself have already put together. So I kind of threw mine away and I'm just putting this one up. So you got a patient low pretest probability, D-dimer negative, you're done. D-dimer positive, do the ultrasound. If it's negative, then you don't have to anticoagulate those people. You can just repeat it in about a week and make sure that it's negative. Make sure you didn't miss something really small. If it's positive on your ultrasound, you're done, and just anticoagulate. Send them to see their doctor. Moderate to high, do the ultrasound, the D-dimer you're not using there. If you're positive, anticoagulate. Negative, I don't think a lot of people do this, but this is really smart people to put this together, and I think it's a good approach. Negative, this is moderate to high pretest probability, so a negative ultrasound, you still have maybe some chance of having the disease. So do a D-dimer, and if that's negative, then you really feel like you've kind of excluded it. And if it's positive, then you're going to, again, repeat the ultrasound in 5 to 7 days. Just the same as over here when you had a negative scan and a positive D-dimer. The only thing I would say about this, and I would hate to correct something that is this nice, is that I've gotten to a point to where if I have a low pretest probability patient, why exactly am I doing a D-dimer in those patients?
That's my exact question. I mean, if you've got 100% sensitivity for an ultrasound, you don't have 100% sensitivity for a D-dimer.
Right, and of course, we actually don't have 100%. We know it's not 100%,
sure,
but it's pretty close. And actually, pretty much all the studies you look at, the negative predictive value and the positive predictive value for ultrasound and for D-dimer in these low-risk patients is around 97 or 98%. So a negative D-dimer or negative ultrasound is just as good as a negative D-dimer, those operating characteristics of that test. So to me, when I see a patient on the board that says leg pain and swelling, I go in the room to see them and I roll the ultrasound machine in with me. I mean, why would if I came in and you were seeing me, Mike, first off, I would ask for another doctor, and then I would not want to be poked and wait an hour or 2 hours or however long it takes you to get a D-dimer back.
No, you want an ultrasound.
I would want it 3.5 minutes. You bring it in,
go home.
They look, and then you go home.
This is an inherent problem that we have in emergency medicine in multiple different areas right now, because we've got these clinical decision rules that clearly the evidence is very good for. Like the one that we're looking at right here. Wells criteria is a clinical decision rule that we really can't refute. And we don't have those kind of rules for ultrasound, but we, as emergency physicians, know that ultrasound is extremely sensitive in these cases. So it's pretty challenging trying to mix this evidence-based medicine that we have in front of us to make the right decision. I got to say, I've moved past D-dimers also in these patients. I just ultrasound them. And I don't think that that's necessarily standard of care right now.
And it's great to have her like this because not everyone is comfortable with ultrasound right now. And obviously, low-risk patient, negative D-dimer, DVTs excluded. That's great. You can totally use that. But if you are proficient with ultrasound and you've had 10 minutes or more of training.
and 3.5 minutes to perform the scan.
Yeah, then, it seems like a no-brainer to me. You're not poking the patient. You're not taking all that time. And it's got just as good of operating characteristics for low-risk patients. So that's how we should do it, and that's how I do it. Other places that can have DVTs, we'll just start real quick. Internal jugular vein, obviously, and you can identify these the same way, just with compression. I had a patient when I was in the ICU as a resident. I remember trying to put a line in, couldn't pass the wire, jabbed and jabbed and jabbed, and then finally looked and they had a big IJ clot. So we're not talking about studies or anything like this, but you compress anywhere where you think there may be a clot, and you can see if there is a clot or not. In the arms, it would be great to have someone like Michael Blavis on to interview, but he wouldn't come on for interview on this episode, but he at least sent us a picture of his arm to use in this part. Also, subclavian is another place where you can have clots, and
I think another quick place just to mention is the iliacs is a place where you could definitely have deep venous thrombosis that are at high risk of embolization. The upper extremities aren't as at high risk of embolization. So, despite the data that we have that we're very good at ruling out DVT in the lower extremities, if you've got a high pretest probability in your patient population and you've got a negative bedside ultrasound, that doesn't necessarily mean you're completely done. If you really think they've got it, then you probably need to look at their iliacs.
That's a great point. Unfortunately, this is like everything in medicine. You actually have to think, and you can't just apply every decision.
I hate that, man. God.
But, so, that's it. A quick quiz for you. Mike, can you adequately do this?
Yes.
I think you're right. How many compression points are needed?
4.
Or 2?
Oh, 2.
Yes, exactly.
Okay, sorry.
So 2 points.
I was thinking both sides.
Okay, yeah, you're doing bilateral on everybody just for fun. All right, so that's it. Oh, actually, one more question. I'm sorry. Name the 2 points.
So the one on the left is the up in the junk point, and the
also known as the common femoral vein, the takeoff of the saphenous.
And the one on the right is, if you can find it, back in the knee point.
Yes, which is the popliteal vein. Very good. So this looks like this has been about 20 to 30 minutes. So 100% sensitivity after 10 minutes. You should be 250% sensitive after watching this. I guess that would be if we were as good as Jang and Lovato and Chris, which we're probably
not true.
Well, we're probably 25% as smart as those guys. So if you watched 40 minutes of this,
like
you will
watched
be
it twice,
100% sensitive. Exactly.
So
I think that's how
just watch this
works.
again, and you should be okay.
Just
right?
start over from here, and you'll be 100% sensitive the second time you watch this.
Okay.
All right. So, Mike, you want to do real quick letters on this episode? I've gotten a couple letters recently in the mail.
Yeah, let's do some letters. What do you have?
All right. So I got this letter recently. Let me read it for you, and we can respond. Dear Mike and Matt, thank you for starting this podcast. I'm a second-year emergency medicine resident, and I listen to all the emergency medicine podcasts I can each month to supplement my training. I felt there's been a void without an ultrasound-specific podcast out there, and I'm super stoked you guys are filling that void. The only thing that could be done better is if we got more close-ups of Matt and less video of Mike. I actually paused the video and took multiple screenshots of Matt to use as my screensaver. I could stare at it forever. Sincerely, anonymous emergency medicine resident. Well, thanks for writing us. We appreciate the feedback.
Who was that? Phil Craven?
So, actually, that's not a real letter for any of you who couldn't tell. But we would love to hear from you and get some feedback. Tell us what we're doing horrible and what we're doing well. Or just, you can write something similar to this and make us feel really good.
Yeah, go on the Facebook, comment on Facebook, send us an email, emergencyultrasoundpodcast@gmail.com. Or, just send us a letter. You can write.
Hopefully. Thanks a lot. If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.